Thank you, sir. Respected Professor Malik, sir. Padma Shri Dr. Lahane, sir. Professor Dr. Malik, sir. Professor Dr. Ruchi Goyal, sir. So like Dr. Malik, sir said that everybody is a phaco-surgeon, but like Lahane, sir always says and Malik, sir always says that out of the lakhs of surgeries that are done in India, majority of the surgeries are SICS. In a subluxated cataract, we were always worried whether we would be able to do IOL implantation. Otherwise, in the past, it was always an intracapsular surgery. What causes subluxation? It could be trauma, previous ocular surgery, multiple intravitreal injections, Marfan syndrome, homocystinuria, pseudoexfoliation, Weil-Marchesani syndrome, sulfite oxidase deficiency. These are some of the causes which cause subluxation, as we all know. There may be a stable subluxation or it may be progressive. The management would differ in those cases. So trauma and previous ocular surgery, multiple intraocular, we have already seen this. So these would cause progressive and generalized weak zonules. How would you manage the case of subluxation? It is very important to investigate and examine the patient properly. A pre-operative precaution. So when you are examining the patient on slit lamp, you have to measure the amount of clock hours of subluxation, and one must always remember that that subluxation which you see intraoperatively will be more than what is seen on slit lamp. You have to take pre-operative precautions. The counseling of the patient is very, very important. Intraoperatively, the procedure will be different than your standard SICS because you may have to use devices. There will be an extra intraoperative time, and post-operatively, the patient will require steroids or close monitoring and management. Even after the post-operative period of 6 weeks is over, you have to observe the patient closely for secondary glaucoma or decentration of the intraocular lens. So all these factors are very, very important. Continuous monitoring of the patient to examine the retina, because whatever caused the subluxation could have also involved the retina. So these are very, very important. Slit lamp examination, UBM examination, B-scan sonography, retina examination. These are also important from the patient point of view and also important from the medical legal point of view, where you have to document everything, because the patient is very sweet when he comes to you, has a lot of expectations, and later on he may create a lot of problems. UBM is a very valuable tool today to UBM is a valuable tool today to, there is one slide which is not seen only, okay. So pre-operative counseling, like I said, is extremely important. Explaining to the patient the need of complicated or prolonged surgery, the need for a vitreoretinal surgery or a vitreoretinal surgeon standby, the risk of retinal detachment post-operatively and or cystoid macular edema. So all these needs to be explained to the patient, because when you are in the OPD, you have 4 or 5 patients and they come for follow-up at the same time and they will discuss ki mere ko to ye drops diye, I am not seeing so well. So all these are very, very important. Intraoperatively, also you have to be very careful as to there may be a problem and how will you manage. So if there is a zonular dehiscence up to 4 clock hours, you will use the CTR with an IOL implantation. Up to 3 clock hours, again CTR with IOL implantation. Greater than 3 to 6 clock hours, modified CTR with a single loop. Between 6 to 9 o'clock hours, then a double loop CTR or some modified devices with IOL implantation. And very large subluxation, you may defer the in-the-bag IOL and you may prefer to do a SF IOL or iris fixated lenses. So that is why the number of clock hours of subluxation is very, very important. Now, when you are planning the incision, normally you would do a superior or a superior temporal incision in SICS, which is good because it is covered by the conjunctiva and the upper lid. But you won't try to place the incision away from the zonular weakness and opposite to the zonular weakness if possible. If not possible, because you can't do an inferior incision, you can't do 2 temporal and incision in a complicated surgery. So you should not jeopardize your ability to try to do acrobatics. You have to do it in the most reasonable and the most scientific incision location possible, and then manage whatever comes your way properly by keeping a vitrectomy standby. viscoelastic is very, very important because here you are going to manipulate. You must remember, when I was learning, Dr. Lane sir always told me, and Dr. Patel sir, my teachers, that treat the cornea like God. Because if you are doing a good surgery, it may look very good on the next day, but if the endothelium is compromised slowly, it will decompensate. So you have to treat the cornea with a lot of respect, and you have to use a good viscoelastic. Capsular rexes here will be, because the capsule will be loose, so you have to plan. So it is better to stain the rexes. You can use forceps and needle so that you have better control, and that is why it is very important. Now, one thing you must remember is that the lens is subluxated or decentered, so the rexes should be centered on the lens and not in the center of the pupil, which is dilated, because ultimately you will be fixing the bag. So the rexes should be centered on the lens. One must remember that. So as you can see, this is a subluxated cataract. The capsule has been stained. The incision is a sclerocorneal tunnel. We are now doing and centering the rexes on the lens. And as you can see, the lens is very considerably subluxated, so making a small rexes and not going too near the area of subluxation. So there the rexes is not very large, and one is successful in making the rexes after the tunnel has opened. Hydrodissection, you have to be very, very careful while doing these hydro procedures, because it can cause amount of fluid inside the bag and the bag to subluxate more. So one has to be very careful. Small amount of fluid in multiple zones is very important. Orientation of the IOL. Now, when we are using a rigid IOL, the size of the IOL is big, and with the haptics you can enlarge the bag. It can be centered, it can be positioned. So these rigid IOLs are a boon, and you have to manage to put the IOL in such a way as to inflate your bag and to center it. So that is very, very important. So there are two schools of thought: in a plane parallel to the zonular dialysis, or in the area of zonular dialysis, one haptic. So stretching the bag is very, very important. Capsular tension rings have been a boon, because these were the ones which helped us make this into an extracapsular surgery and not an intracapsular surgery. So there are various types of rings and sizes available. When you measure the white to white in a patient before surgery, you would be able to judge the size of the ring that would be required in a particular patient. Now the CTR, the time of insertion is before the removal of the cataract or after the removal of the cataract. One has to customize it according to the case, and you have to insert it in such a way that you hold one and you use specially designed forceps to insert the ring. Now, as you can see over here, this is the CTR ring. You are holding one edge and you are inserting it into the other under the capsule. So it goes inside the bag, and it rotates because it is circular. So you have to gently put it, and then when the end is there, you put the dialer inside the loop or the hole which is there, and put it inside the bag. You have to be very, very careful, because in lots of patients we have found, when we were doing a second vitrectomy surgery for a patient, 2-3 CTR rings in the vitreous with one more IOL in the vitreous. So it should be done only when you are comfortable and you are able to do it. So it can be done before phacoemulsification or before SICS nucleus delivery, or it can be done after nucleus delivery, whichever is comfortable and whichever is important for that patient. So if you're doing it after nucleus delivery, it should be stabilized till nucleus management. You can stabilize it with iris hooks, and it can be inserted with simple forceps. Correct? So what are the contraindications to a CTR? If your rexus is broken, if there's a PC tear, if there's extensive zonular weakness, otherwise you will have the CTR inside the vitreous. And so that is very, very important. So this is the rexus. You can see the subluxation and the crenated margins, where it makes evident that the nucleus is subluxated, making the rexus again important to be centered on the lens and not in the center of the pupil, so that you will be fixing the bag and then it will be centered. We've already seen the placement of the CTR, but we can see it once again because it's a very, very important step. It needs a little bit of technique to put the CTR. It is not very difficult. One must remember that it is circular while inserting it, and you have to, it spins and it goes circularly inside the bag. Once you are used to putting it once or twice, then I think it is easy to learn how to put it. So once the CTR is in place, as you can see over it, the bag is already stretched and extended, and then after the removal of the cataract, it's very easy to put in the IOL. You can see the CTR. Here the IOL is being put with the AC maintainer in place and dialed. So the CTR, what it has done is it has enlarged or centralized the bag. It has supported the bag and it has inflated it so that the position, there is ease of putting the IOL. Now, post-operatively, you have to monitor the centration of the IOL. You have to remove, post-operative means in the period during the surgery, you have to remove the viscoelastic. You have to check the shape of the pupil. If you have to see whether there are any vitreous strands and manage it by doing a vitrectomy or staining it with triamcinolone acetate, you have to monitor the intraocular pressure post-operatively. There will be pseudophacodonesis if the subluxation was large, and that itself will cause cystoid macular edema. So preventive measures by giving NSAIDs is important, because cystoid macular edema in the long term will cause cystoid macular degeneration and a drop of vision. Retinal examination, because you have done so much of manipulation with putting in the CTR rings and removing the cataract and all that, so you have to see the retina very, very well and keep an eye on the retina so that you may not have any other complications. Patients have to be explained the need of closer follow-up. So you can give very good results in a subluxated cataract with proper planning, a proper expertise. And I would always say that I started doing all these cases after a reasonable amount of expertise, because there is no point in messing up a patient in the earlier on stage when you're doing SICS or surgeries. These patients can always be referred to a senior surgeon, because ultimately at the end of the day, the patient and his vision are important. One mess, it is very difficult to salvage an eye, but at the same time, starting with a small subluxated cataract with a small zone of subluxation where a CTR ring can be pushed, can be managed. Thank you so much, sir. Thank you, Kamaljeet Singh, sir, for giving me this opportunity to present the case, present with such stalwarts in SICS, sir. Thank you so much.
Thank you, Dr. Ragini. And now I will call upon Dr. Kamaljeet Singh, sir.
Sir. So trypan blue has been known in many cases, even in mature cataracts, to stain the vitreous. But once you put the trypan blue and stain it, you cannot be sure that it will go behind. There are cases, even without a subluxation, in a mature cataract, when you are giving a wash, you see some amount of blue staining. Diluted trypan blue would be safe. And I think that the vitreoretinal surgeons, I think Pranav would be able to say, that they use trypan blue to stain the ILM also while doing. So I think that trypan blue which they use would be safe to use.